morning, everybody. I think we're going to get started. Welcome to this conversation about public-private partnership. We are incredibly lucky to have 4 leaders, innovators, Medicaid managed care plans, who are right in the middle of the mix of figuring out how to bring innovation into the Medicaid managed care market. I'm Jocelyn Geyer. I'm with Manette Health, and I'll be moderating today. And I'm going to ask each of our panelists just to say hello. The only comment I want to start with, I'm very excited about the panel, with the notable exception that my microphone is not as fun as Paris Hilton's last night. Did you guys see that? I'm like, what's up with that? Where's that microphone for us? So, but other than that, this will be an equally fabulous session. So, do you want to start? Just hello, name, company, role.
Sure. Can you hear me? Okay, good. Hi, morning. I'm Steve Chukmakian. I'm the Chief Medical Officer for UHC, United Healthcare Community Plan, here in Arizona. So that means I oversee our 4 health plans, which is a dual special needs plan, and then 3 Medicaid plans, 2 of which serve individuals with special health care needs or long-term care needs. And I'm a family practice physician by training. I've been in the role for 13 and a half years.
Great, thank you. Why don't we go this way, Travis?
Good morning, everyone. My name is Travis Gales. I'm the Chief Health Officer for Hazel Health. We partner with schools to provide virtual telehealth services, physical health and mental health, to children at school and at home. I'm a pediatrician, adolescent medicine specialist by training, reformed former health department director before joining Hazel about 3 years ago. Excited to be here with you this morning.
Great. Okay, Pooja, you want to go next?
Hi, good morning. I'm Pooja Mittal. I'm the Chief Health Equity Officer at HealthNet, which is a Medicaid managed care organization in California. We actually have Medicaid, Medicare, and commercial members, including exchange. And our footprint is across the state of California, so quite a diverse population. I'm a family doctor by background.
Hi, everyone. I'm Gaurang Choksi, the founder and CEO of Violet. We partner with health plans and health systems to really build health equity and build and scale culturally responsive networks.
Great. All right, so you can see we have this incredible mix of both people sitting at plans and people who are innovators. So why don't we start with, from a plan perspective. So I'm going to turn to Steve and Pooja first. Lots of people want to partner with you all. Lots of startups want to work with Medicaid managed care plans, but they don't necessarily understand your point of view, the barriers that you're facing. So tell us, from your perspective, what are some of the things that you wish startups knew about the challenges and how they should think about approaching you?
Sure, thanks for the question. I think there's so many different things. I'll just talk about a couple that always come to mind for me. One is that it takes a long time. And so I think, people who come from other industries and then come into healthcare, they expect that it'll be like a 6 to 12 month turnaround for you to get your foot in the door to get business at a plan. And in the plan world, especially the Medicaid side, it often takes 18 to 24 months, if not longer. And so a lot of that is about relationship building, just like everything else we do. And it takes time to really understand if it's going to be a good fit. So that's one. The second I would say is really ensuring that the people who are coming to the plan with a solution, if it's a Medicaid plan, are thinking about Medicaid, right? They're designing that solution specifically for our Medicaid members, because what we don't want to do is sort of try and retrofit something that's been designed for a commercial population onto Medicaid, because it doesn't often work that well. And then I would say the last thing is that comes to mind for me is, how do you, as the person coming in selling me something, plan to drive engagement with your solution? Because that's often the thing that I see, is that people come to the plan expecting that me as the plan, I'm going to drive engagement. But I need to hear that from you, because I have a million things that I'm doing. And so how are you going to go out and make sure that we're getting people to engage with your solution and actually get the benefit from the solution that you're bringing forward?
So 3 good thoughts for folks to. Steve, you want to jump in?
Yeah, sure. So those are all excellent. I agree. In addition, I think a couple of key things that I would also look at as a health plan chief medical officer is the solution and the ideas being brought forth, are they indeed specific to a community need or a select community need that we're looking to resolve and solve for? Obviously, that usually comes from conversations with us or with other payers in the market, or potentially with our state regulator, who have priorities, and if their priorities are our priorities. So I think that's another key one. The other thing is that, albeit we have some, at times, investment opportunities to help support startups and beginning initiatives, in the Medicaid space, obviously that investment opportunity is oftentimes pretty tight and pretty small. So we have to be pretty selective around the partners that we are engaging with. So if you have data or experience when you're bringing and presenting a solution, that's really, really helpful. And very helpful is a roadmap or a path for a sustainable, reproducible model. Sustainability oftentimes turns out to be like one of those very gray areas in the conversations that I end up having. And that's okay, because lots of times with new partners, we can help them solve for that based on our individual market here in Arizona. I realize that the sustainability approach might be different depending upon each state Medicaid agency and what they permit the health plans and the MCOs to do.
Got it. Okay, thank you both so much. I think that gives us the plan perspective. And now I want to kind of turn it. So for those of you that have been innovators and have done this, what were some of the challenges once you got deep into it that jumped out at you?
Sure. I think challenges are always evolving and persistent. So when you solve one, you encounter another one because by virtue of encroaching in the new space. I think particularly in this area, some of the challenges that jump out are one, to Steve's point, are we meeting the need of the children or the families that we're serving? And as that need evolves, are we staying up to date with what those needs are and having an understanding of what those needs are? Are we doing a good job of demonstrating impact? And do we have a clear set of metrics that are able to be reflected back to the populations that we're serving, to the payers to be able to convince them to cover, to investors around, are we meeting the needs from their perspective? I think the third thing is, particularly as we're trying to marry and meet equity and address equity and access, are we leveraging technology in a way that creates innovative solutions while also leveraging innovation in the space around support services? So for example, in the pediatric space, we've got great technology that is allowing us to be able to offer virtual therapeutic services, which increases access points for many kids who otherwise would not be able to get those services. But at the same time, are we innovating the strategies around supporting wraparound services and case management that we know will also be needed to be successful? Are we innovating strategies around identifying and capturing social determinants of health, which we know will impact families? Are we also innovating strategies around how we continue to engage those populations, but help them navigate through the healthcare system? Because we do celebrate the fact that many more kids have health insurance today. Actually, most, if not all, do. But are we helping families navigate the services to know what they're eligible for and how to reach the services that they should receive? And the last thing I would say is, considering we're talking about Medicaid populations, is we know historically when we create innovations, they typically favor commercial insurance. They get it first, and then there's a kind of a multi-tiered system where if you're on Medicaid, you're getting a watered-down version of what that innovation is. And so the challenge is, how do we make sure that in creating these innovative technologies and new service delivery options, that we're not perpetuating that multi-tiered system, and we're creating equitable access up front so that we're also starting to see equitable outcomes as we move forward.
And Pooja, I feel like that's part of what you were saying too, is don't just hand me something from the commercial market. Make sure it's tailored to the unique needs of the Medicaid population. So, okay, you want to jump in?
Yeah, on my side, I'll add really two main things that have worked for us. One is authenticity. I myself, as the founder, grew up on Medicaid for about 10 years. And most of my partners know that lived experience, and it's helped a lot. You know, being able to personally speak to, hey, a $10 copay, a $5 copay, a $20 copay, that's the difference between a parent being able to take you to the appointment or not take you to the appointment because they can't miss work. So being authentic as a founder or as a partner and showing up authentically has gone a long way. And the other thing that we really focus in on is collaboration. As Steve said, everything from what is our current roadmap of what we're trying to prove out from a clinical impact perspective to what's the technology that's there or the pricing strategy that's there and how do we collaborate to become better. So for us, authenticity and collaboration has really helped a lot.
And that might get us to our next question, because we started, and it's not very behavioral health savvy of us, we started with the challenges. We didn't do a strengths-based approach, so let's flip it to the strengths-based approach. Like, what's the positive part of this? And really, I think beneath this question is like, why do you do this work? Why are you in the space of working with the people who are enrolled in Medicaid? And on this one, I'd love to hear from everyone, so why don't we go, do you want to just pick up on the authenticity point? We'll come on down.
I'm happy to start. So I myself, in a lot of my introductions, I always share with my lived experiences. I think that helps a lot, and frankly, it just builds a connection of why we do the work we do. So I myself, outside of growing up on Medicaid for a long time, I immigrated to the US when I was 10. I'm also a gay man, and I built a health plan for many years called Oscar. So all of those experiences combined really just showed me how valuable and how much we need investment and technology to really advance health equity in our country.
So as a family doctor, I get to see this in my practice still. So I work at an FQHC, and every day when I'm seeing patients, I see what challenges they're confronting, and it's different per different community, per different language, per different background, and per different family structure, right, based on the support that people have. And so that, and then also a lot of the health challenges that my family has been through, even as a physician and as somebody who's quite privileged in this space, having to navigate healthcare that's culturally competent has been very difficult. And so both of those things really inform the way that I show up in my work every day, really trying to improve health outcomes and experience for everybody, because everybody deserves great healthcare.
Thank you so much, Steve.
So I'll go start back a bit further. So when I first decided to become a physician, I really wanted to ensure that I had a holistic training approach. I think it was part of the reason why I chose an osteopathic medical school, in addition to my father being an osteopathic physician. But and I think that carried forward into trying to select what type of field I wanted to be in, and I liked everything and everyone. So family medicine made a lot of sense. And then when I came out of training, I really wanted to serve a diverse population, so my practice was downtown Phoenix. It served a very diverse population, but of course in that it served a fairly heavy Medicaid population, and got to take care of families from a generational perspective and learn a lot of things from my patients that I didn't learn growing up. I don't think I had as much of a lived experience, but I think all of those experiences sort of brought me to where I am today, which was a managed care company offered me an opportunity to get involved in a way, and at first sort of feeling like that wasn't the path to go, and then having really more of an internal conversation that, well, if I do that and kind of put medicine aside, what's the impact I could have on the population on a larger scale? And that sounds a little bit canned, actually, but it's really true. I really took that leap and said I would do the job for like a year or two, and I'd see how it would go. I didn't want to make a long-term commitment, but then I realized once I was in it, yes, I missed the direct patient care experience, but I was able to interact with companies and people who are trying to find ways to transform the system, and I could help shape that and to some degree pick and choose and try to find the best solutions to try to help us innovate and bring care and increase access. And so that has been really rewarding, and it's why I've continued to remain in the space, because those opportunities have just grown over time.
Great, Travis?
In addition to what has already been said, this is advantage when you go at the end. You can say kudos and whatever everyone else has said is great. I would add that, beyond lived experience, one of the things I found, and having come from academic medicine and being in government, is the reality is when I walk into most rooms as a decision maker, there are not many people who look like me, love like me, and represent the areas of the different parts of my demographics. Yet many of the people who are in Medicaid, for example, do look like me and come from a lot of those areas. I'm from a rural area. And so I have tried to make a professional commitment to give voice to those communities that have historically not been a part of the decision-making process. And one of the things that used to stick out to me the most, probably more so in government, when designing interventions, is often hearing people talk about those communities as difficult to reach, hard to reach, resistant to access, lazy on uptake, when in reality, if you create systems that remove barriers and create meaningful access, those communities will utilize the resources at comparable, if not higher rates than others. And when they do, they demonstrate really good outcomes. And so your answer is to why, continuing to be connected to this population, it's because, most of the folks in the population are not represented the decision-making process. And because of that, to Pooja's point about cultural competence and culturally relevant care as part of the decision-making process, their voices need to be heard, because otherwise, unfortunately, the interventions, whether innovative or not, are not designed to meet their needs in a meaningful way and further perpetuate those inequities.
Okay. Yeah. So you guys are in it for the money. I'm just kidding. No. Thank you so much. I mean, it really is, I think, important to get a sense of why you're there, and it's part of why you have such a huge impact, including at that larger policy level, well beyond individual care. So I want to take a little bit of time just to think about and talk through, when you think about creating value for members of underserved communities, and that's the language we're using today, how do you think about value, and kind of what are the outcomes you are hoping to achieve? And think about it maybe through both. There's some, we're all very focused on quantifiable data and outcomes, but are there also intangible pieces that you think about as you do your work? So, and that one is also for everyone. So maybe we'll just reverse the order.
Happy to start. The way we think about value is patients have to get better faster, and if our work isn't achieving that, then as a company, we're not succeeding. That's been our North Star since inception, and it's what we really focus in on. And so pragmatically, what we've done is, starting at a very early age in the company building process, we started looking at clinical research. And so the way we work at Violet is we partner with health plans like UHC, regional Medicaid plans like UCare, to really understand how inclusive is the network, how inclusive is every single provider, and then we provide education to help them become better. And what we measure objectively with every single provider is who's doing what training when, and the training is specifically speaking to health disparities and clinical best practices. And then we look at, are we actually observing the outcomes we want to see? We've been pretty privileged. In some states like Colorado, we even have payer partners paying more when the providers become verified inclusive, which is now aligning incentives and really building systems where we can advance equity for all of the members that we want to improve access for.
Yeah, I love that, and I think, so what I'll do is I'll talk a little bit more about the intangible, because as a health plan, we clearly look at closing disparities, gaps, and improving health outcomes as our primary value proposition. But as we think about more broadly how we define value, maybe I'll tell you a story. So in 2017, HealthNet started a community doula project in Los Angeles County. And we actually seed funded a community-based organization to start up and train doulas to take care of Black women in Los Angeles County and provide doula services. We were one of the first Medicaid plans to do so, and we were really excited about it. We had funding for it that I got through quality by pitching it to our quality side. And we entered into this relationship very open, and from the beginning trying to share power and have the community-based organization take the lead. And suffice it to say, we learned a lot about power sharing and how it doesn't work that easily. And even though we went in with that intention, it was kind of a mess, actually. There were a lot of things that went wrong. Our relationship almost dissolved several times. We had to stop, and people didn't get paid for a couple of months, which was really hard, and then we had to restart with a whole new structure. So it went on for a long time. In the end, we served half as many women as we had wanted to. So we served 85 women. In that group, the outcomes were great. Now, we could say that that was a success because those outcomes were really good, right? Decreased C-section rates, improved birth outcomes. But actually, I think the biggest success that came out of that is that we as partners persevered and we kept coming to the table together. So this organization that we had seed funded is called Frontline Doulas. They are now the premier doula organization in California. They sit at the table for the state benefit to actually help co-design the benefit to make it more equitable. And we remain great partners. And we talk all the time, we work together all the time, and we listen to each other. And so one of the things that they called out was, this benefit is now available. It's actually paying really well. California has the second highest paid doula benefit for Medicaid. But one thing that we're missing is this ability to convene together and build community. And so now we're coming to the table together to write that grant together and do that work, and we'll fund that so that the doulas in LA can build relationships together, and Frontline's going to lead that. But we've had at least 3 or 4 grants in between where we've continued to partner together. And to me, that is a huge success, and that's another way we define value. Are we showing up as trustworthy partners? Are we building trusted partnerships? And are we improving people's experience, not only our members' experience, but also our partners' experience in their relationship with us?
So interesting. We're going to come back to that partnership building in a second, because I think that's a fascinating piece of how you're thinking about value. Steve.
I think some of my comments are going to be very, very similar and reflective. I would say that each partnership we engage with, we really take it one at a time. Each one is different. Each one needs to be, I think, unique, and we need to listen and take it at the value of that proposition, since it might be serving a rural community, or might be serving an urban one, and one might be trying to address a health inequity, and one's trying to address just standard HEDIS quality gaps in care. So it really depends upon the nature of the relationship. And to that end, I think part of the way we objectively measure it is, okay, is that specific relationship, the way it was designed, the way it was expressed, is that actually then achieving the goal? I mean, that's really straightforward, but is it? If it's not, that doesn't mean it's a failure, or that we pivot away. It might mean that we have deeper conversations about why that's happening, and why that's not being achieved and reached, and how can we refocus or reapproach things. Sustainability, I touched on that earlier. That's a big one for us, because so often, again, the ideas are great, but we can't find a way. We can't look forward, say, out a year or two, and let's say this is successful. How are we going to ensure that we can continue that successful program if we don't first think about the sustainability now, right at the very beginning? So I think something that's else we look for. On the intangible side, you touched on experience. Our patient and your patient member experience is huge. If the goals might be getting met, but people are having a poor experience, I feel like it's not going to translate into kind of what you touched on earlier, which is you want to focus on that the core initiative, but you don't want to lose sight of the fact that you're now engaging with an individual that may have been previously not engaged in care, and what are the other opportunities you can then offer them through wraparound and other types of assessments, and then how can you connect them into the broader community of care and outside of the specific program. I would say the other thing is that trust and credibility is one of those intangibles as well. I think, and we try to be cautious, or at least thoughtful about that. If the community partner is not trusted and credible in the community, there's a concern right up front that may be setting up for failure, or at least a lack of success. And then the last thing I would say is that there are great models that are presented to us that may fit a specific gap or need in a community. However, there may be an existing solution that's already meeting that need in the community, and those are partners of ours too. So we want to balance the idea of bringing in new partnerships to address different gaps and different needs without disrupting existing relationships and successful partnerships we have in the community.
Okay, so be really careful. You can't just walk in and plunk a new partner down. You got to think about the existing structure. And I also want to come back on the financial sustainability, because you've mentioned it a couple of times, and it strikes me that many people think of Medicaid MCOs as the source of sustainability over time. So it's interesting that from an MCO perspective, you're flagging that. Okay, Travis.
I'll just close out on one thought. In thinking about how we look at equity, we are going to have to become more nimble in terms of how we're defining that, particularly in today's political climate. Pre-election and certainly going to be post-election. And one of the things that we are very thoughtful about is in how we are communicating return on impact. So we certainly look at clinical impact scores. Is there an improvement in the child's pre and post screener? Is there an improvement in how they're feeling before they saw our physical health provider versus going back to class? And so thinking through how do we translate those into other, metric-driven approaches. For example, the child's improvement in their PHQ score, does that correlate to improvements in attendance? Does it correlate to improvements in academic performance? Does it correlate to improvements in behavioral referrals, which we know are huge other areas where we see inequities that are impactful and also tied to resources. So I say all that to say that as we continue to move forward, being more thoughtful about how we can expand the impact of what we're doing, to be able to tie that to other areas where we see inequities that disproportionately impact this population. And also as we start to think about funding mechanisms in the future, still to be determined, but I think we're going to have to really be creative when we're thinking about Medicaid funding on a national level, Medicaid funding on a state level, and how we continue to support these programs and initiatives to meet the needs of the population.
Yeah, it's a different universe this week than last week, I think, when it comes to kind of Medicaid funding and equity. And let's actually go there. So even before the election, we were going to talk a little bit about, particularly from a managed care plan perspective, what are the priorities from a behavioral health, equitable behavioral health perspective? Kind of what are you thinking about focusing on for your priorities in the coming year? And I realized it's only been a few days since we realized there's going to be a shift in leadership in Washington. But if you can add in how if at all, that shift in leadership might affect your priorities in the coming year when it comes to equitable behavioral health. And I think maybe we'll start with the managed care plan. So, Pooja.
I would say we have three big priorities for our approach to behavioral health this coming year. One is to really build even more on our school-based behavioral health work and try and we're really lucky that we partner with Hazel. We have physical and behavioral health in schools, but bringing more services to the schools and wrapping around their families through community health worker support and other types of support is one big priority. So we're really honing in on school-based health and school-based health for the whole family. The second is dyadic care. And so thinking about providing behavioral health services in tandem at the point of primary care for children. So that's another big priority of ours is how can we do more of that integrated behavioral health care in the primary care space. And then the third is maternal mental health, because we are doing that well in certain places, but not great in other places. I think screening is a challenge. Implementation of access to care is a challenge, and so that's a place where we're putting more structure and more strategy over the next year. And as to how the shifts are going to affect that, I'm hoping that these are all things that we know are important, that we know we can push through, particularly at a state level. I feel like I'm very lucky to be in California because the conversation's different there than a lot of other places. And so equity is still really at the center of our managed Medicaid structure, even in the quality strategy and the state-delivered population health management strategy. And so I'm hoping that we can hold that line and just continue to push that work forward.
Yeah. And Steve, you want to jump in? And you're in Arizona, so you're going to have probably a different experience, possibly.
Yeah, so I could be mistaken, but I don't think the dynamic will change very much around our focus. Our focus is going to remain pretty constant because it's evidence-based, it's common sense, it's obvious in many instances. So I think that we're going to continue to try to do the best we can. We talked about this just briefly, but I mean, there's a data paucity that sometimes guides us in the wrong direction, but we're going to continue to collect as much data as possible in a way that reflects people's willingness to offer that information to us, with the hope that that's going to help empower a health plan using data and analytics and partners in the community to bring the right solutions to people at the right time. So I'd say that about the dynamic. When it comes to initiatives, it is about meeting people where they're at. We hear that a lot. So a lot of our focus has been around mobile access, trying to bring care into communities where that care doesn't exist. So we've invested and supported March of Dimes with a mobile unit here in Maricopa County to go into communities where access to care currently doesn't exist. We've invested in Brighter Way Dental Partnership to bring dental services and care to people and children in need where they're not getting it. Those are indirectly or directly behavioral health related because if we're not addressing those needs, we're not having the touch point where we can engage with people and identify those additional needs and get them referred or get them into services. And I kind of skipped over social. There's still a huge focus on trying to identify social determinants, get screenings to occur, but then make it easier through a closed loop referral system, which is being built here in Arizona between Access, the state Medicaid agency, Contexture, the HIE, and the health plans who are invested in this, so that when screenings are conducted, there's a network, a digital network, if you will, of the ability to refer people in for those services and then have a closed loop where that comes back to the referring entity and provider and so forth to know that those needs have been outreached to and addressed. I'm trying to think. And the other thing that is on our minds is workforce. There's significant workforce challenges in both physical and behavioral health spaces. So we're also working with our state partner and something called Pipeline Arizona to create a career hub in Arizona so that we can also help promote and engage and connect people to the right education as well as into the right resources and tools and positions so that we can try to improve and engage and expand the workforce generally, but also specifically where it's needed the most.
Okay, super helpful. Thank you both. So throughout the conversation, I think you all have actually been fabulous about giving us specific examples, but I wonder if we can kind of, in this next portion, dive into even more specifics. And to set that up, Greg, do you mind just going a little bit deeper on what you all do and giving us the rundown on it?
Yeah, absolutely. So prior to building Violet, I built a health plan called Oscar for many years. And it was an individual marketplace plan. And one of the fantasies or goals we had was in every single city or market we went to, we wanted to build a culturally responsive network. Meaning if we were going to Chicago and we knew 22% of Chicagoans were Black or brown, we wanted at least 22% of the doctors to either be trained in Black or brown communities or specifically either have lived experience and be Black or brown. What we quickly found was, one, in America, in any city, we just don't have enough diverse clinicians in the first place. That's a systematic failure. It's going to take us a long time to change, but I really hope in my lifetime that changes. The second thing we saw was there was really just a need for data. Really what we were trying to figure out was there was no data that said this provider is objectively inclusive working with gay men or working with communities of color. With Violet, what we ended up doing was leaving Oscar and building that technology. So we operate almost like an accreditation framework or a credit agency, but for every single provider in the country, we take a deep dive into what are all of the communities they worked with, what are all the communities they belong to, or communities they really want to work more with. And then what we do is augment that with clinical education. So we specifically teach about what are unique disparities affecting every single community and how can that provider not just speak to the identities of the member, but actually address disparities for that member. In the simplest words, what I've always said is if a provider can't say the word gay to me as a gay man, they're not going to speak to disparities that affect gay men. So we do both. We teach about how do you build that muscle or confidence of saying and actually speaking to identities, but then how do you speak to disparities that that member really needs to know or preventive screenings that need to be delivered. And we've been pretty fortunate. Now we partner with 6 or 7 different Medicaid plans across the country, but really each of those is an individual partnership. And in the partnership, we work with each plan to figure out what are the disparities we're addressing in their market. So in some states like Colorado, a huge focus is on rurality and rural communities. Whereas in other states like Minnesota, we're really focused on urban communities and how do we actually address disparities either for the LGBT communities or BIPOC communities. To specifically speak to impact, this is where I get really excited. The main thing that matters for us is, are people getting better faster? And so Kay leads our clinical research here, there in the front, but we do a lot of research specifically looking at, can you actually train providers to become more inclusive, and are their patient panels getting healthier or better faster? And we have leading indicators and research that the answer is yes, we can train for that, which is exciting.
That is exciting. If the answer were no, we would be in serious trouble. Travis.
Sure. So behavioral health in the pediatric population is, and this kind of gets to your previous question, is actually one of the, I think, few topics that has had success in getting support across party lines. I mean, we work in red states, blue states, rural areas, urban areas, and there seems to be agreement that this is a fundamental problem that we have to work and support. So I'm hopeful that regardless of administration changes, that at least on a state level, that commitment will remain. And to Gaurang's point, of being able to work with different states allows for the opportunity to have conversations around different components of Medicaid. So Medicaid reimbursement rates, what are the support mechanisms in place for those wraparound services for families. Our model is we're in over 17 different states. We partner directly with schools first. Schools create a mechanism so that all of the students in their district have access to our platform. The platform originated as a short-term therapeutic model, but now it's an ongoing therapeutic model for students who can be referred in by parents, family, school staff, and in some places themselves. And so they meet with our providers, work through our therapeutic models, and we track their outcomes. We've been able to demonstrate that there's over 70% improvement in clinical symptoms for kids coming in with anxiety and or depression. And again, going back to the earlier conversation, what's most exciting for me is that we're seeing that impact for all communities, regardless of the zip code that they live in, regardless of the race and ethnicity, as well as across gender. That's significant because I think as we continue to build models, it's really about removing those access barriers for communities to be able to benefit from that. A couple of the innovative strategies beyond the therapeutic model that we put into play is we've created spaces for young people to actually participate in building what works for them. We were having a conversation earlier about certainly in the younger generation today, as an adolescent doc, I don't speak fluent teenager anymore. And it's important to create mechanisms for them to be able to be a part of that building process so whatever interventions are built will resonate more clearly with them and have more of an immediate impact to demonstrate that it's working.
Okay, so interesting. And I feel like that might give us the bridge to get back to that conversation about partnerships, that lead-in you gave us around the importance and the power of working with young people. And I know you had set up earlier that part of what you do is build relationships, the relationships you described with the Jula organization. So let's turn to partnerships. And just, we're getting a little close on time, so we'll do one more, your thoughts on partnerships, and then we're gonna close out with final advice. So would love to hear, as you think about the partnerships that you all each have been engaged with, kind of what are the key lessons that you would take away from what's worked, what hasn't? What advice do you have to other people who are looking to engage in these types of partnerships that you've all been talking about?
I mean, I think, Steve, you've touched on so many of them, but I'll just maybe reiterate. Fit, I think, is really important, like really bringing both partners to the table and coming together to a conversation or a decision around what you want to partner on and how it's going to work. Intentional power sharing, when you're the large private organization and you're the one that has the money, you're essentially the funder, right? So intentionally power sharing so that people feel comfortable coming forward when there's problems or things aren't working out as expected, because that happens in every partnership. And then I would say also, and just to highlight what Steve said, is the sustainability piece as well, I think is really key. And partnerships are also about people, and so all of us coming, at first, I think it requires cross-sector work. If we're really gonna move forward equity and behavioral health across the next 50 years, we're gonna have to work together across public-private partnerships, but also with community members and bring that expertise to the table and compensate for that expertise, and actually build those relationships over time and maintain those relationships as well.
For me, it's really, there's no one size fits all. Be open, be authentic, and we found that whether it's working with a policymaker, working with payers, working with other stakeholders, there's just no one size fits all. Be collaborative and open, and that really has been the key to success.
Great, thank you, Steve.
And just taking a few different angles, and working for United, which is a big company, patience sometimes is a virtue with their partners. Didn't you allude earlier that sometimes it can take a couple of years to, that's a little frustrating maybe at sometimes, especially for innovators that want to move quick and move now, but it's difficult sometimes to move that quickly. So patience I think is a virtue of the partners that we work with. Flexibility and adaptability, right? We're often presented with a fairly specific solution, but I think partners who approach us with a willingness to well, you said this earlier, consider the individual market, listen to the feedback, and potentially adapt and or modify and shift the model a little bit, especially around the edges, to better meet our particular needs. I think that's very helpful. And lastly, engagement. I mean, that seems obvious, I think, but I've been involved in relationships where engagement levels are excellent and high, and those invariably result in quicker outcomes and results. Whereas if we get started and then engagement drops off, that oftentimes results in worse progression and at least less chance of reaching the goals.
Okay, thanks.
I think another important thing is knowing what you can do well and able to execute well and scale up well, and when to call in help or partner with other folks to be able, who can do it maybe even a little bit better. And one of the things that we recognize as a company was we have ambitious goals, but in some instances, it's better for us to be a convener and a connector as opposed to the provider of the service. So we've shifted a little bit to say we can provide, therapy, we can provide, immediate care from a physical health perspective, but there may be instances where our big role is helping that family navigate the system and connecting them to a long-term medical home or to a long-term therapist that they may benefit more from than the model that we have.
Okay. Yeah, so that leaves you again with partnerships as a strong theme, right? Because you're figuring out where your role might best stop and you're working for those handoffs. Okay, we have just a minute or two left, so why don't we just take the last sort of a free-for-all final thoughts for folks. What advice or what is the most important thing you would like to leave people with? So we'll go down the line again.
Oh, I feel like a broken record, but continuously just being authentic. As a first-time founder, one of the most rewarding things for me has been being able to bring my full self to all the rooms and seeing so many of the governmental or Medicaid partners be receptive and really celebrate my identities.
Yeah, I'm just going to support that for Gaurang because their team came to pitch to us a while ago, and we were in the room with a bunch of executive leadership, and his team is relatively young compared to everybody else in that room. And the comments that came out of that conversation afterwards were like, wow, what an incredible group of young people, because they really, they're in it, they care, and they brought this incredibly authentic, diverse perspective. And one would think that wouldn't be the sort of response from a group of executives, but that does shine through from your team. So I just wanted to give you kudos on that because it's something that we noticed on our side. So maybe the thing that I would highlight again, and I'll sound like a broken record, is relationships. It's all about the people. And how do you make and build authentic relationships with the people that you're partnering with the people you're trying to serve, and with the people in your organization so you know how to get the right things through and get buy-in from the right people.
Great comments. At the end of the day, we're really looking for solutions that are going to transform the healthcare system. It's complicated and complex, multifaceted. So at the end of the day, we're really looking for solutions that are sure innovative and new, but that are going to really result in that transformation we're looking for. So I would just say that it all kind of comes back around to how are we going to change the healthcare system so that it works better for everybody, and that we're going to increase access to care and engage people who are otherwise often routinely marginalized or disengaged from the healthcare system.
Great, thank you. Travis.
Just a reminder to take care of yourself, because the work that everyone's talking about, building these partnerships, fighting these obstacles, removing these barriers, is heavy, it's exhausting, and it can take a toll. And if you can't be of help to yourself, you can't be a help to anyone else, or it's challenging. And so just making sure to check in, take care of yourself, whatever self-care mechanisms you need to avoid burnout and exhaustion, because by doing so, that will keep your mind fresh to be innovative, fresh and friendly to want to partner with other people and open to ideas, and it'll just keep you around longer. So please don't forget to do that.
All right, well, that seems like the right place to end this. Thank you all so much to our panelists. Let's give them a round of applause.